Hi, I'm Devinder Grover, and I'd like to thank you all for inviting me to speak on GATT. And I really want to focus on really the tricks of GATT and make this more practical as opposed to going over the data. I'd like to thank the Arvind Eye Care System and Dr. Swati for inviting me to speak on this MIG symposium. And I hope this talk provides some nice insights into this technique. These are my disclosures, none of which are really pertinent to today's talk. I really want to start off with a basic overview of GATT, then discuss some intraoperative tricks, show kind of some basic pearls, the instruments I use, kind of discuss some of these advanced tricks, really then discuss just my indications, who I perform GATT on, who I don't perform GATT on, and then try to wrap this up. So initially, let's talk about an overview of what is a trabeculotomy. A trabeculotomy was classically done ab externo under a flap after a conjunctival dissection. It was relatively invasive. It's not a new surgery. It's been around since the 60s at least. Redmond Smith, one of the great thinkers of angle surgery, first described this in the 60s. And, Morton Grant wrote one of these landmark articles demonstrating that in primary open-angle glaucoma, the vast majority of the resistance to outflow was in the trabecular meshwork. Now, he reported it was 75%. David Epstein redid this study and showed it was about 66% or 60%. Regardless, we understand that the vast majority of resistance to outflow in primary open-angle glaucoma, and actually in a lot of the secondary open-angle glaucomas, is the trabecular meshwork. So let's talk about what GATT is. And GATT is a 360-degree ab internal trabeculotomy that we termed the GATT surgery, gonioscopy-assisted transluminal trabeculotomy. And this was initially described and first performed in 2011. It's been almost over a decade now. And this is an illustration just demonstrating the key portions of the steps of GATT. First, you make an initial goniotomy, then you pass the suture ab interno 360 degrees, retrieving the distal end, thus creating a 360-degree ab interno circumferential trabeculotomy. This can be done with a catheter or a 5-0 Prolene suture. Again, here these still shots of the key portions of the GATT surgery. Let's talk about it. Let's show the first video. This is an instructional video I put together on GATT because it highlights a lot of the key portions. This first step is blunting the suture. And first I'm going to blunt it, and it's going to make the blunt too large. And if you make the blunt too large, the blunted tip too large, it'll have a hard time getting around the canal. So if you do that, it's easily you just cut the little tip off and then pre-blunt it again. Make it just the minute you see that change, that's when you're done. You just want to see a small little blunt. Here's another trick that I like. Before you even start, just guess the circumference of Schlemm's canal. That's really, once that suture is passed, that's when it should be done. So what I do is you can make a little kink in the suture so that if you see that kink, you better see the distal end of your tip. Otherwise, the tip of the suture has gone somewhere else. And I'll show you that in a couple of examples. You start off with a paracentesis, a temporal one, and an infranasal paracentesis. You can see my infranasal one, this is a right eye, is pointing towards the nasal angle. It's a phakic patient. I will oftentimes use Myocol. And then this is a little bit of Helon GV. And I'll initially put some on top of the cornea, and then I'll use it to maintain the anterior chamber and inject it in the anterior chamber. I then like to place my suture through the infranasal paracentesis. Then I tilt the patient's head away from me, the scope towards me. And you really want to make sure you have a nice view of the angle. And you can see there's not a lot of blood reflux. And why is that? And that's because I have the patient's head above their heart. Then within the eye, you grab the suture, and then you want to go as tangential to the back wall as possible. And in truth, the most common spot for going in the suprachoroidal space is that first 90 degrees. Once you get past that first 90 degrees, you've passed one of the biggest hurdles. Then after about 180 to 200 degrees, you're going to start to feel a little resistance. And that's how you know you're in the right spot, because you're pushing this way and the suture is going that way. And that's a good sign. Now look at this. Here you can see that kinked tip. and you can see my distal tip. So I know that I've guesstimated the circumference of the canal appropriately. I go over my suture and externalize it. Thus, you have a 360-degree trabeculotomy through two small paracenteses. Here, I'm just going to irrigate all the Helon GV out of the eye with balanced salt solution. And then watch the episcleral blanching, this episcleral venous fluid wave that we also described, my partner and I, Dr. Ron Fellman, back in 2012, really seeing a blanching. Look at superiorly at the top of the screen, a blanching of these episcleral vessels. You're diluting them with balanced salt solution, confirmation that the patient has an intact outflow pathway. Now, is another nice example of just a bimanual irrigation aspiration, this time demonstrating the episcleral venous fluid wave. And I like this video for a couple reasons. One, it's a nice example of the episcleral venous fluid wave. Two, right now you're seeing me just in irrigation aspiration. What I'm going to do next is I'm actually going to do a lavage of the collector system. And with balanced salt solution on a cannula, I'm just going to irrigate and elevate the pressure quite high, probably in the 25 millimeters of mercury range. Look at that. You see this diffuse blanching, especially up top. It's almost like you're cleaning out the out downstream collector channels, almost a lavage of the outflow pathway. This is confirmation that the patient has an intact outflow pathway and that GATT is successful or will likely be successful in this eye. And it gives you a good insight into the patient's outflow capacity. Now, what's nice is, although we developed GATT at our practice over 10 years ago, it's nice to see that GATT is now spread around the world, and there are published data and reports from around the world on outcomes, reporting relatively similar outcomes that we reported in our group. So it's always nice when this data can be duplicated. So let's talk a little bit about some intraoperative tricks. And the first one is what happens when you have intraoperative bleeding. So here's a nice example of a GATT. I've already performed a goniotomy, and you can see I'm going to go as tangential as possible to the back wall of Schlemm's canal. Then I'm just going to pass it, and you want to watch, again, you want to watch that the suture stays in the canal, and the point of maximal deviation is that first 90 degrees. And once you get past that first 90 degrees, you're home free. Now, this patient has a more highly pigmented trabecular meshwork, which makes seeing the distal tip of the suture a little bit more challenging, but you just got to make sure you continue to focus and don't give up. And then right when you start to give up hope, then you start to see the distal tip come around 360 degrees. And here you can see that right now, shining through the trabecular meshwork, you can see the distal tip. Now I'm going to reach over the suture and carefully grab the distal end of the suture and externalize it. Be careful not to grab any other structures. What I like to do is actually just hold it there and then come off the eye, and then with my other hand I will pull on the distal end. Now watch in the nasal quadrant, you're going to see some bleeding, and this is a phaco GATT. So I'm going to move up to the head of the bed to do my phaco, and you start to see the eye fill with hyphema. Nothing to worry about. Just put in some more viscoelastic, keep the anterior chamber formed, and actually use the viscoelastic to burp out the rest of that blood. You can also wash this out when you do your phacoemulsification. You can see the pupil will sometimes come down, so you may have to use a device to help expand the iris if that is the case. And what happens if the suture pops out of the canal? Here's another video. Now, here's another example, again, making a goniotomy. And I like to depress on the back wall of Schlemm's canal, so you can see that white strip. And as tangential as possible. Now, this blunted tip's a little bit big, but it works fine. And you want to just continue and just watch it go over that first 90 degrees. And once you get past the first 90 degrees, you have the comfort that you're in the right place, and you're likely not going to go into the wrong place. Now, like I said, you expect to see some feedback, especially after the suture is past 180 degrees. Now, sometimes you'll feel that feedback, but sometimes you won't. and or sometimes you feel it, and then it stops. And what happens in this situation is, you can see I'm passing it and I'm passing it. This is when that kinked suture helps, because you know when you're expecting to see the distal tip. And I'm passing and I'm passing. I'm not getting the resistance I expect. And but look what you see coming around. You see the distal tip, but it's not in the canal. It actually had popped out. So here you have to investigate where it popped out. And oftentimes it'll pop out in the subincisional space. So you can see that kinked area pop out, and it pops out right at the subincisional area. So then I stay in there, and we have to go the opposite direction now. So I make another paracentesis, this time in the supranasal quadrant. And now you have to pass the suture clockwise. Uh, and what's interesting is, now that you've opened up half the canal, um, passing it the opposite direction is sometimes a little bit easier. Always maintain your chamber, refill the eye with viscoelastic if you need to. And there's also some viscoelastic on the cornea that helps with the view. Now, sometimes I'll use the same goniotomy site, so you don't have to repeat the goniotomy site. And again, make sure you're in the canal appropriately, and then just slowly start passing it. And what's going to happen is, you'll pass and you'll treat the remaining 180, but it'll actually be a little bit easier because you've already opened up half the canal. And what's also interesting in this situation is, when this occurs, the suture tends to just ride in the back wall of Schlemm's canal. It doesn't pop out. So you will feel some resistance. Again, remember, I kinked that suture, so I'll expect to see that kink if I've gone too far. You can feel some resistance. That's a good sign. You're going to see I'm feeling the resistance. And then right again, when you're about to give up hope, um, you see the distal tip of the suture coming through. And again, it's riding in the back wall of Schlemm's canal. So go over it. You've already treated that area. And now you'll see that when I come off with my gonio prism, I'm just going to treat the remaining 180 that wasn't treated. Here, I'm going to pull on it. You can see that I'm just treating that remaining 180, and you can see where we can actually feel where that suture had popped out initially. Now, here's a nice video demonstrating what happens if the suture can pop out, and it actually can get embedded in the iris. And this is a very subtle finding, but you got to identify it, because if you don't identify it, you can cause damage to the iris. Things such as an iridodialysis or sphincter tear. So again, the same way, I'm starting with an MVR blade and passing it as tangential as possible. And you want to make sure you passed around the first 90 degrees. And then I'm passing it and I'm passing it, and I'm not feeling that feedback. You can see I've kinked the suture right there, and my kink has gone through. I see that kink, but I don't see the distal tip of my suture. Now, what's interesting is I see the iris kind of having this dimple in it. Now I'm going to pull back on it, and you can actually see that the suture had come out and has now gone posterior to the iris and was pushing up on it. Let me show that again. I'm going to pull out, and you're going to see that it comes a little posterior to it. So now I'm just going to kind of walk the dog, and I just treated that initial 90 degrees or so. And then I'm going to go the opposite direction. Now, it's key to identify that, because if you didn't identify that, you could have caused some significant damage to the iris, as that iris popped out of the canal, dove posterior to the iris, and was starting to dimple the iris. Now, again, here I'm careful to make sure I'm in the canal, and I'm watching it as I'm passing it. And just gentle, slow, steady bites, passing it. And again, having that kink in the suture really tells you when you expect to see your distal tip. And if you see that kink and you don't see your distal tip, that's when you stop, pause, and look for what may be occurring. Such a key portion. And this is not necessary with the catheter, but it's necessary with the suture. So there, it stayed in the back wall of the canal. I've now treated 360 degrees. And thus you have the 360-degree trabeculotomy. Now, what happens if the suture stops? So here's another example. Um, again, passing it as tangential as possible. Now this time, I'm taking slow and steady bites, and as it's gonna just not move anymore. And you can see, you wanna be careful not to cause any damage to the back wall of Schlemm's canal. If you're pressing too hard, the suture can bow back and cause a cyclodialysis cleft. So you gotta be a little bit careful. And you'll see I'm gonna just gently press to get some slow bites, but eventually, if it just doesn't work anymore, you need to stop. Otherwise, you're going to cause some harm. So after I've really tried my best to pass it, what's nice about the suture is that when it does stop, if you just pull on the suture, it actually will treat the amount of trabecular meshwork that it's already circumnavigated through. So I'm going to pull on it, and you're going to see that I'm going to treat about 180, and boom, right there is when it pops out. So you can see I've treated that superior half. And then just like you saw in the previous video, I'll make a paracentesis in the superior nasal quadrant, take out my suture, pass it around. Now I'm going to go clockwise. And what's nice about, again, this example is that as I'm passing it, I will still feel some resistance, but it won't be as great because half the canal has already been opened. Additionally, the suture just rides the back wall of Schlemm's canal, and it stays in place, which is nice. So there I see my kinked suture, and then I see my distal tip as well. So I'll reach over it, obtain it, and then complete a 360-degree trabeculotomy. So here we're seeing this evolution of trabeculotomy in adults, and I think GATT is a continuation of that evolution. And as GATT continues to spread around the world, I hope to see a further evolution by all the great minds, the people that are doing GATT, to make it even better and come up with the next best step. So what do I use for GATT? I'll just put this up there. You can take a still frame of this to show what I use for my suture GATT as well as my catheter GATT. Now, what are some pearls for the beginning angle surgeon? One, you have to understand angle anatomy. You have to also be comfortable with performing intraoperative gonioscopy. I would say initially start with a goniotomy or a bang procedure or something that doesn't require a lot of manipulation in the anterior chamber at first, just to get a sense of that before attempting GATT. I'd also say it's nice to start off with a pseudophakic patient. That way you're not worried about the complication of performing a cataract surgery, as well as possibly damaging the lens during this procedure. You have to maintain the anterior chamber at all times. And put your patient in reverse Trendelenburg. That minimizes the blood reflux. And you can see these two images on the screen, one with blood in the angle, one a clear structure. The reason why you have the clear structure is my patients are in reverse Trendelenburg, and that minimizes episclerovenous pressure. And I actually do all my surgeries like this, all my angle surgeries, all my cataract surgeries, all my tube shunts, all my trabeculectomies. Every surgery I perform now, is my patients are in reverse Trendelenburg. I think it's safer, and it minimizes the risk of bleeding with angle surgery. I think it also minimizes the risk of a suprachoroidal hemorrhage. Now, you want to make, as I mentioned before, the smallest blunt possible. Keep the anterior chamber formed. You always have to have a good view and be gentle. This is microsurgery. It should not require a lot of aggressive movements. Just be gentle and be nice to the eye. It doesn't require a lot of strength. It requires finesse. Place a small amount of Helon on your gonial prism or on the cornea to maintain that seal. And if you can't see, stop and use viscoelastic to push away the blood. Reverse Trendelenburg, and if there's too much blood, just wash everything out and reform the eye or increase the reverse Trendelenburg. About experienced surgeons, so you can see what I like to do in my right eye patients. I always like to make my side wound infranasal, whether it's right eye or left eye. So in right eyes, I'm passing the suture counterclockwise, and in left eyes, I'm passing the suture clockwise. That's so that once you've passed about 270 degrees, if it does stop and you need to retrieve it, you can move to the top of the bed and reach, and it stops at 6 o'clock. Now, based on the level of blood reflux and the episcleral venous fluid wave, I will vary the amount of I will vary the amount of helon that I leave in the eye. If I see a tremendous wave and a huge amount of reflux, I will leave a decent amount of helon, maybe even 30, 40%. If I see a minimal wave or minimal blood reflux, then I'll leave a minimal amount of helon to protect against an early postoperative hypotony. Now, we talked about if the suture stops, you can pull on it and then go the opposite way. If you're using the catheter and it stops and you pull on it, the catheter will just snake out of the canal. So it'll be a couple little tricks for the catheter, almost like you're walking a dog and pulling it, because the catheter won't stop and treat the otomy and create an otomy. Here's just a comparison of the catheter versus the suture, showing the significant cost difference. I actually think the suture is a little bit easier to use as long as you understand where you are. When you have an abnormal angle, sometimes the catheter is nice because you can see the blinking light and you know that you're in the right place. When do I perform GATT? I perform it in mild to moderate stages of primary open-angle glaucoma, all stages of secondary open-angle glaucoma with and without cataract surgery, and in patients with real glaucoma who need real IOP lowering. These are not the patients that just have ocular hypertension on one medication. I would say the best patients, as I mentioned, the mild to moderate open angle glaucoma, primary open angle glaucoma, avastin-induced glaucoma, pseudoexfoliation, steroid-induced glaucoma, non-granulomatous uveitis, once the eye is quiet, even traumatic glaucoma, primary and congenital glaucoma. Without question, this is the gold standard surgery for primary congenital glaucoma and juvenile open-angle glaucoma. And, it's interesting, compared to the patients we see here in the US, in India, eyes are not typically treated with drops for 10 to 20 years. And I think that makes a difference in outcomes. And you can actually do this in patients that I've done in India with tremendously good outcomes because their eyes haven't been abused by drops for 20 years. So I think in all stages in primary open-angle glaucoma, if the patient has not been on a lot of drops. I do not perform this in patients with very advanced glaucoma where I think they have a lot of scarring and they need a trabeculectomy, or patients that need a pressure of 12 on no meds, patients that can't be taken off blood thinners or can't limit their activity and sleep with their head above their heart, patients with an unstable lens, or just broad areas of PAS and scarring in the angle. Here's my typical postoperative regimen. The first week, aggressively treat with steroid and antibiotics. If the pressure is above 17, I will add pilocarpine at night. Pilo is my first medication that I add back. If the pressure is even higher, above 22, I'll add pilo to twice a day. At 1 week, stop the antibiotics and slowly cut down on the steroid and slowly taper the steroid. Limit their activity for a couple weeks and have the patient sleep on the side of the surgery, because blood will pool temporally, that was the left eye, and you'll protect the nasal quadrant, which is, as we know, been shown to have the greatest outflow capacity. If the patient has a layered significant hyphema after 1 week, I have a low threshold for taking them back to the operating room to wash out that blood and the blood clot. I keep them on steroids until the eye is quiet, and then I slowly taper it. My first drop back is pilocarpine, followed by a beta blocker. And if the eye is quiet, sometimes I actually will leave them on a steroid and pilocarpine once a day for a couple months. And then I will eventually, if I need to, add back latanoprost. So in conclusion, GATT is a safe, novel, minimally invasive conjunctival sparing surgery. The success that we've reported is quite significant at 24 months, with cumulative proportions of failure anywhere from 0.18 to 0.35, and cumulative proportions of needing reoperation from 0.9 to 0.4. These were in a pretty unique group, and we cut that out as actually somewhere between 0.9 and 0.28. So quite a decent levels of success. This is not a new surgery. It's a modification of a traditional surgery that's been around since the 60s. We do need longer follow-up in this cohort, and we're in the process of reporting on that. I'd love to see a prospective GATT study performed. I think we need to start thinking about and talking about cost-effective delivery of healthcare, especially when it comes to glaucoma surgery and MIGS. And I think without question, GATT is a very cost-effective method for lowering pressure. And it's just in general, there's a learning curve, but it's no different than when you first learned cataract surgery. You must always maintain the chamber and maintain a good view. do perform this in patients in reverse Trendelenburg. Be gentle. This is microsurgery, delicate microsurgery, and have the patient on high FEMA precautions for about 2 weeks. This is from my friend and colleague, Bryce Ford out of Canada. He did a price per millimeter mercury analysis of all types of MIG surgeries, showing that GATT is without question one of the most cost-effective MIG surgeries available. And no, this is not a map of COVID. This is a map of, as far as we know, as far as I know, the number of countries where GATT is being performed. And I believe it's in over 27 different countries and growing, which is exciting to see. And for those of you who wish to learn GATT, once the world opens up again, I have an open door policy in my operating room. If you ever want to come out to Texas and come see me in Dallas, every year we still are teaching a course at the American Academy of Ophthalmology. And please don't ever hesitate to contact me if you have any questions. I'd like to thank the whole team at the Arvind Eye Hospital, especially Dr. Swati and Dr. Venkatesh for making this course happen and for inviting me. It's always a privilege and an honor to spend time with you all, and I look forward to seeing you continue to adopt GATT into your practice patterns, and hope that will help all the patients at the Arvind Eye hospitals. And I also look forward to the chance of coming back to India once the world opens up, and learning from you all and sharing my knowledge about GATT and other surgeries as well. So thank you for your time, and please don't ever hesitate to call me or email me if you have any questions, or you can also visit my YouTube channel. Thank you.